Hey, good morning, everyone. Let me know if you can hear me. Someone posted they couldn't see the lecture. I posted it up. Oh, hold on. I see here. Well, let me know. Hey. Anyone there can, I know there's a couple people watching. Can you let me know if you can hear/see me? There we go. Okay. Yeah, sorry. I had the link posted up in the announcement, but I guess I accidentally left the thing hidden. So you should be able to see the PowerPoints now. That's okay, as long as like someone can hopefully relay questions. Good. All right, can you guys access week 1 and get to the PowerPoint? I hope. Be able to see. Let me know if you can access the PowerPoints. Start here and just has something in it. Instructional content. PowerPoint should be there. You guys not seeing what I'm seeing? You found the link to the video, so I'm hoping through the course. Okay, good. And we'll spend the first couple minutes just kind of talking about the course and how it's all set up and whatnot, and then we'll go from there. Yeah, and that's I'm totally down with you guys watching as a class. That's no problem. The only thing I worry about is not being able to kind of like engage everyone. So even if you, um, you know, are able to just like pop into the video, so that way you can at least like ask questions, that would be helpful. So even just having the chat open can be useful for you, or posting up on the sticky board, because I'm really finding the more engaged you guys are in asking questions and we can talk about stuff, the more sort of like the live lecture sort of experience you get a little bit, and also can uncover you know, maybe some misunderstandings or things like that, so that way I can try to answer them for you and also for everyone else at the same time, which is going to be handy when you're taking your exams and what. Anyway, let me get start recording here. So it's 8 o'clock. Thank you for joining me here for Pharm 2 early this morning. Let's see. When I get to the PowerPoint, it says no items in the learning module. Is anyone else having issues with that? We go to week 1, should be introduction and pulmonology, and then there should be under instructional content. I can just make another announcement. And I'm not sure why you guys can't get to this. Spring 21. You guys can see my blackboard here. It's a fun way to start the first lecture. Attachment. You refresh maybe? Are other people able to get to it? Like, can anyone get to the PowerPoint? Okay, good. Yeah, I think I'd probably just click the button there. So just, if you can't see it, maybe refresh or log in, log out, and you should be able to get to the course content there. So it should be under week 1. Good. All right, fantastic. Thank you. Good. I'm glad everyone has it. If you are still having issues, perhaps email it around. I'm not sure, but you guys should have access to that. Everything else should be hidden for now, but anyway. So so this is Pharm 2. This is basically going to be run pretty similar to Pharm 1. Note this is only 2 credit hours as opposed to 3 from last semester. So you may notice some of the weeks are a little bit lighter in terms of content. That's because it's just fewer hours there. And so, this is kind of how the university has it set up. Anyway, we'll still have so I think I incorporated a few more quizzes in here just for practice for you guys. To have some ideas of kind of what sort of things will be on the exam to better prepare you from that standpoint. So there will be a few more of those you'll notice. There's one this week, in fact, that you should take. I checked it, made sure all the matching sort of works out. Found out that having multiple correct answers is just not a good way to do that through Blackboard. It's not very well set up for that. Anyway, other than that, we'll still have the similar, we'll still have 3 exams, non-cumulative. We'll still have the a prescription assignment, so we'll see those pop up, and I'll go over those in more detail when we get to them in their respective weeks. But really, all you have to do this week after the lecture is check out the quiz, take that, and then you should be good to go, and you'll have an idea of how we're going to do things for in terms of from week to week. Other than that, the grading setup should be all the same. You can see the syllabus if you look on here. Where's my syllabus at? Syllabus schedule. Yeah, so you can find the basic schedule there. You can check that out if you want to. And then you should be good. The schedule is at the bottom of that, so that's why I went ahead and blanked that one out. You can see the original in the syllabus. So if you have questions on how the course is going to be run, please let me know. Otherwise, I think we're good to go. All right, so you guys, there are no questions up here so far. So courses you go through, if you have questions, post them up on the sticky board in the chat. Nothing about that has changed necessarily. Otherwise, we can go ahead and start going to the lecture here. So feel free to interrupt me at any time, no problem. And we'll kind of get at it, right? So anyway, kind of nice thing about this class, I don't have to go through a bunch of intro stuff and all that. We can kind of just hit the ground running with our material here, but anyway, let's start off with pulmonology. So I'm going to get a chance to talk about last semester here, but first off, just some antibiotic stuff. So kind of getting us back into the swing of things a little bit in terms of refreshing your mind a little bit, reminding you that you can't really dump all the stuff you learned from last semester in terms of drug interactions we're going to run into and things like that. So when we talk about things like QT prolongation for antibiotics, like you can't lose all that stuff from first semester because it still applies here, right? It'll still apply in your clinicals. So that's kind of some of the challenges some people will have is when things start to kind of pop up again and again, they have some trouble sort of thinking like, oh yeah, I got to be able to recall some of this stuff, at least some of the major points, right? And I'll make those points as we kind of go through the lectures as we do these here. Make sure my phone is on silent so you don't hear the buzzing. Anyway, so getting into some of the antibiotics, let's just talk about bronchitis real quick, because I'm sure this is something that you're going to run into pretty frequently with your patients, especially like in urgent cares and ERs and whatnot. We'll talk about pneumonia a little bit more in detail here in just a moment or two, but basically this is an infection of the bronchioles, of the bronchi, not really getting down to the bronchioles and alveoli. That'll be for pneumonia in just a few moments here. You'll find this can really happen to anyone, but you'll find it primarily in patients who have either like chronic lung disease. COPD patients especially tend to be more likely to see this, and it kind of makes sense because of the fact that, over time smokers tend to lose a lot of that mucociliary clearance, and they have all kinds of epithelial issues in those cells, and so they can't really clear those infections as well. But anyway, important things with pulmonary antibiotics is to realize that not everything is going to require antibiotics, and that can be a challenge for your patients, because if they take the time, maybe time off work, and they come and see you and they have to pay a copay, and you just tell them, yeah, you feel bad, but there's nothing we can do about it, go get some rest, they're not going to really feel like they really got their money's worth, right? So a lot of people have sort of the expectation for a prescription of some sort, and frequently they want antibiotics. But it's important to realize when that's appropriate and when maybe that's not so appropriate. In terms of common upper respiratory tract, and then we'll talk about, kind of bridges that into lower respiratory tract stuff. You see very common bacteria popping up here, right? So if you recall when we talked about ENT stuff last semester, we saw some pretty common organisms like strep pneumo, we saw H. influenza, we saw Moraxella catarrhalis. You will find a lot of those same bugs still popping up here as well. So it's good to remember sort of what type of bacteria there, so that way we know what kind of antibiotics to use, and there's going to be some crossover between what we talked about ENT to now, so that's good to know. Certainly other things you have to worry about too are going to be what we call our atypical bacteria. So this can include things like mycoplasma, chlamydia, bordetella, things like that, and that will require some different antibiotic management, and those bugs you didn't quite find so often in upper respiratory tract infections. One thing to consider too is these patients may start off viral but then have secondary bacterial infections, in which case, you may find some practitioners that'll say, okay, well, I'm going to give you a script for an antibiotic. Don't fill it, but if you haven't improved in so many days, then yeah, go ahead and get it filled, and we'll go from there. So really just depends on the situation. They have recurrent bronchitis, or this is kind of a new thing for them. Generally speaking, though, it's pretty self-limited, so we don't oftentimes have to really do anything, right? So it's kind of one of the situations where you just want to kind of hurry up and do nothing, basically. If they're having fever, we can give them antipyretics. We can give them acetaminophen. If they are having excessive cough that is maybe keeping them up at night, we can do antitussives like dextromethorphan and other things we've already talked about. One thing you may want to avoid are going to be things that dry the patient out excessively, because that may decrease their ability to really get rid of those bronchial secretions that may contain the bacteria. So it kind of makes things more viscous and harder to clear. So things like antihistamines like Benadryl, and a lot of the antihistamines you find in over-the-counter cold and cough remedies, so like chlorpheniramine and brompheniramine, things like that, stuff we talked about last semester. And then some pathomimetics like Sudafed. Those would be things that you probably want to avoid, just because it has a chance to prolong their symptoms there, right? But overall, fluids are always going to be important. Make sure they can stay well hydrated, because they may be feeling crummy and not want to get enough water, right? For the most part, you don't need to necessarily use any antibiotics. However, this is a really common reason for inappropriate antibiotic use. Most people just kind of pull the trigger and say, okay, here's your Zithromax prescription, or here's your Levaquin prescription. And that leads to a lot of unnecessary resistance, as we're going to see here. So we want to try to prevent that if we can. But who do you probably want to treat for bronchitis, because their likelihood of having a bacterial etiology for their disease present are going to be those that maybe have symptoms greater than 5 days, right? So that's why maybe they come in with a 2-day history of symptoms. You say, okay, well, here's a script. Don't fill it for 3 days, right? Because then at that point they're still sick. Then perhaps it is bacterial. For these patients, we're mainly going to be seeing that in terms of our preferred antibiotics, we are going to want to include atypical coverage. So things like mycoplasma that we mentioned there. And so a couple of here we have options include our doxycycline, right? Remember, that's a tetracycline antibiotic. Obviously would not have that being preferred in children if we can avoid it. And things like macrolides like azithromycin, erythromycin, or clarithromycin, any of those would be fine, but recall that they get overused a lot, and so that's why I see a lot of resistance. And so over time, we're kind of switching back to doxy a bit, so that way we can try to relieve some of that pressure and hopefully lose some resistance to the macrolides over time. And generally, we don't want to use our fluoroquinolones like levofloxacin, ciprofloxacin, mainly because the risk for resistant strep pneumo is relatively high. So that's not going to be our first stop unless they've been on recent antibiotic exposure, which is kind of showing they've already failed something. So this might be a good backup. So first line, I'd probably say macrolides, doxycycline, or any tetracycline there. And then as a backup, if that's failing, then perhaps consider a fluoroquinolone. Okay. Getting into then bridging bronchitis treatment into pneumonia. First off, we're going to talk about community-acquired pneumonia. Obviously, because we're describing as community-acquired, then there must be another type of acquired pneumonia. So we'll talk about more like healthcare-associated pneumonias, ventilator-associated pneumonias. We'll get into all that as we go forward. But most people are going to get it from the community because that's where they live and that's where they're going to be exposed to it. And you can see this from a lot of different reasons, but it could be aspiration from agents growing in the oropharynx. You could see perhaps if you're around other people that are sick, you're inhaling their infectious aerosols. Sometimes you may find that like pneumonias are secondary infections to things that have spread hematogenously. So for instance, if you have someone who has a UTI, like an elderly patient, they have a UTI that's sitting there kind of just kind of growing, it will spread to the bloodstream and then deposit itself into the lungs, right? So that'd be hematogenous dissemination. Or in some cases, you may even have, for instance, like direct, inoculation due to like maybe like a penetrating trauma or something like that. As you might see that if you work in a trauma center, for instance, right? So in terms of diagnosis, we're going to see that obviously for a lot of like the more simpler community acquired cases, you don't always necessarily have to do cultures for those patients to find out specifically what bacteria it is. Most of the time, if you can just diagnose them based off the history and the chest x-ray, that's going to be good enough for most patients there, right? And that reason for that is because a lot of people do well with just empiric antibiotics, and I'll give you what those options are in just a little bit. Anyone sick enough needing to come into the hospital, you want to make sure you go ahead and get your cultures done prior to the antibiotics, because if they start antibiotics first and then get cultures, there's a chance you're going to have inability for that bacteria to really grow because it's under the pressure of the antibiotic, and so you may not be able to culture anything out there. So timing is important for that. Make sure you get your culture first and then antibiotics, which most people know to do that, so it's generally not a huge issue. Now, that culture you'd be ordering would be a sputum gram staining culture. So the gram stain would be read pretty quickly. It can just tell you are there gram positive or gram negative bacteria present, and then they'll then further culture it out and tell you what specific bacteria it is. You will find that for a lot of routine sputum cultures, that it's contaminated with just spit, basically the stuff growing in your mouth, which may not necessarily be what's growing in your lungs, causing that pneumonia. So for instance, if you find like a sputum sample has a ton of epithelial cells present, it's probably just spit you're looking at, right? The best way would be to do something like a bronchial alveolar lavage, but that's very invasive and usually the patients are intubated by that point. So overall, if you get the culture, it's not always guaranteed you're going to find the bug that you're treating, but you're using your empiric antibiotics anyway, and then kind of tailoring things based on how the patient's progressing, getting better or worse. Just to give you an idea of sort of the bacteria that are most likely to be treated here. And again, you got to know what the most common bacteria are, so that way you know what the most likely bug or drugs to treat those bacteria are going to be when we talk about our empiric therapy. So guess what? Nothing really new here shown up for outpatient treatment. Strep pneumo, mycoplasma, H. influenza, Moraxella catarrhalis. Those are all like the big players here. We're going to see for most of your community-acquired patients, especially those that are well enough to be able to be discharged home with antibiotics, right? For the sicker patients that are having to be hospitalized, whether on the maybe non-ICU floors or in the ICU, then you got to start thinking about broadening out your likely bacteria, because if they're sick enough to be hospitalized, and maybe there's something more, maybe a more nefarious bug is present, right? So this is where we start to think about things like Legionella species. This is where you want to start to think about things, especially if they're being put into the ICU. Think about things like gram-negative bacilli, like maybe you have E. coli in there, maybe the spread from a UTI. Perhaps there is Pseudomonas there. So based on how sick the patient is, we'll kind of tailor our empiric antibiotic therapy for how intensive we need to go. So if I have like a 16-year-old who is coming in for a pneumonia that can be discharged home because they're healthy, otherwise healthy, their empiric therapy might be different than someone who's sick enough to require being intubated and put into the ICU, right? Just to give you some context there. So who might be at risk for certain specific pathogens? People more at risk for penicillin-resistant strep pneumo would be patients that are older, if they've received any other beta-lactam antibiotics. Now, if you don't recall, remember your beta-lactams are like all of your penicillins, all of your cephalosporins, your carbapenems, aztreonam. So again, I expect you to remember some of this lingo that we talk about here and kind of what drugs that's referring to. And of course, if you have questions, you can stop me and ask. That's not going to be a problem there. But if you read something like that, like a beta-lactam, and you're like, I don't remember what that is, please go look it up, or please ask me, because I don't want to leave anyone in the dust here, right? Patients have like relative immunocompromisation, so whether they're on treatment for cancer, for instance, if they are have developed more late stage HIV or AIDS, if they are chronic alcohol abusers, things like that, those are patients that are also more at risk for having these more resistant strep pneumo that otherwise healthy patients could clear relatively easily. And then, of course, you always want to think about exposure to kids in daycare, because daycare is basically a little cesspool for bacteria to be spread around those little individuals. So, say you have grandma get sick, find out if the grandkid that she takes care of on the weekends is going to daycare, right? That could be a sign that more resistant strep pneumo is present, which again will require you to step up your antibiotic therapy, which we'll talk about here in just a little bit. When you're starting to get worried about like enterogram negatives like E. coli and Proteus and things like that, getting into Pseudomonas as well, this is where we start to get more worried about these patients, because if you have pneumonias due to these bacteria, they tend to be sicker. These tend to happen in more medically complex or elderly patients, and so it requires much more intensive antibiotic therapy. But basically, people are living in nursing homes that have underlying like comorbidities like diabetes or other cardiopulmonary disease like COPD. If anyone's been on recent antibiotic therapy, they're more likely to have one of these enterogram negatives show up on their culture, right? Pseudomonas, again, that's kind of towards the top of the list of really the nasty gram-negative bugs we talked about last semester. We think about this in people who have like corticosteroid use. Remember, our corticosteroids like prednisone and dexamethasone can tend to be more immunosuppressive, can end up leading to some of these nasty bacteria to be able to take hold. If they've been on really broad spectrum antibiotic therapy for more than 7 days in the past month, so if they're like on like cefepime, for instance, or if they're on like piperacillin tazobactam, right, all these really kind of broad spectrum antibiotics we talked about last semester, or if they're malnourished, that could also predispose them to this infection. In terms of outpatient treatment here, if they don't have any risk for strep pneumo, you can generally get away with treatment for those common bacteria, the H. influenza, Moraxella catarrhalis, strep pneumo, and mycoplasma. So that includes a macrolide generally. So for most patients, you'll give them azithromycin or clarithromycin. As a second line, you could try something like doxycycline, for instance, okay? Note the pediatric treatment for pneumonia is a little different, but I'm not going to get into that specifically here. We might cover that later in the ped section, but this is generally for adult patients, okay? For adults, you typically find more likely to have atypical bacteria. For kids, it's more likely to be your general upper respiratory tract bugs, right? If they do have a risk for having resistant strep pneumo, like the ones I mentioned previously, this is where you want to consider broadening out your treatment. So you still need to cover for the atypical pathogens, but you also need to step up your game for that strep pneumo. So this may be a case here where we utilize a beta-lactam plus a macrolide. So it would be on 2 drugs at this point. So you could do something like azithromycin plus amoxicillin clavulanic acid, so Augmentin plus Zithromax, for instance. Now, for my purposes here, I'm more going to focus in terms of like testing on drug selection than I am necessarily saying, well, how many days do you dose this for? How much do you dose? How often do you dose it? That's stuff you can look up. If you don't even know what drugs to look up in the first place, based on how a patient's presenting, no reference is going to do you any good, right? So this is why I try to teach you more about which drugs to use, and then later on you'll get more into like, okay, specifically, what dose do I use? How often do I dose, etc. Okay. Anyway, so you could use that combo, or you could utilize a respiratory fluoroquinolone. This primarily includes levofloxacin and moxifloxacin. This is also good for patients that may have a beta-lactam allergy that could not receive amoxicillin or something similar to that. So if they couldn't tolerate a cephalosporin, then yeah, you could try utilizing just a fluoroquinolone by itself there. Typically, strep pneumo rates are pretty, are a little more resistant to ciprofloxacin, so that's why we try to shoot for levo or moxifloxacin for the most part. We call them the respiratory fluoroquinolones. Let's say our patient gets admitted to the hospital, but they're not sick enough to require ICU care. At this point here, we want to go ahead and utilize an intravenous beta-lactam. So this is where something like cefotaxime or ceftriaxone, which if you recall are third generation cephalosporins, are going to be utilized here. We could utilize like a high dose ampicillin, something like that. So some kind of beta-lactam for that strep pneumo, and then plus you want to utilize, more often than not, it's going to be an oral macrolide, so like azithromycin. That's probably the most common. So seeing someone come in for admission for community-acquired pneumonia, going to the floor, Rocephin plus azithromycin, probably the most common one you're going to run into. As an alternative to that macrolide, you can get away with something like a doxycycline, for instance, or you could just utilize a fluoroquinolone by itself. So you may see that occasionally. But again, we try to hold off on using the fluoroquinolones as best we can because of resistance issues there. For the ICU treatment, it's going to be pretty similar, but we're going to primarily get all IV medications because bioavailability is going to be a little bit better there. And then we may want to consider doing MRSA coverage. That's methicillin-resistant Staph aureus, where you can bust out your something like vancomycin, probably the go-to there, right? Okay, so we're seeing more and more cases of community-acquired MRSA, and so that's obviously not great because that is going to be pretty resistant to most of your outpatient therapies. And so you may want to expect that some patients maybe who've had recent influenza that typically predisposes them to MRSA. Again, we're still in the winter months, so you're going to be seeing plenty of patients with influenza. Who knows how COVID affects that necessarily? We don't really know at that point. But and now on the gram stain, if you get gram-positive cocci clusters, that may also clue you in this could be MRSA. And so typically it requires either vancomycin or linezolid. More often than not, we're just going to go with vanco because that's kind of our tried and true sort of treatment there. So that's community-acquired pneumonias. For nosocomial pneumonias, and this is something you're going to run into pretty frequently if you work in the ICUs or work in the ER, you see a lot of these patients coming in transferred from like nursing homes and assisted living facilities and whatnot. But this is basically patients who have developed an infection that was not present at the time of their admission. So this is frequently where it's normally 48 hours after. So they come in for something else and then they develop this infection. And so kind of includes all the hospital-acquired pneumonias, includes ventilator-associated, but it also includes the healthcare associated pneumonia. So patients are living out in the nursing home. That's still a healthcare environment. They probably weren't put in there with an pneumonia, but then they develop it later on. So, and this is very common. You're going to run into this, probably second most common after UTIs developed in the hospital, for instance. And you'll see this oftentimes in more elderly patients than those that are mechanically ventilated. They're sick enough to be intubated. It could be for something totally different, right? You could have someone who gets intubated after a car crash, and then they're on the vent for a couple of days or weeks, and then they need to be put on antibiotics for this pneumonia that they've developed, basically. And it's not great because we know there's a lot of mortality and hospital costs. Not only that, but imagine if you're an insurance company and your patient got admitted for a car crash, but all of a sudden they're treating for pneumonia, you're less likely to want to pay for that. So oftentimes hospitals are going to be footing the bill for the treatment for that, and they don't want to do that. So there's a big push in hospitals to make sure patients don't get nosocomial pneumonias, because not only is it good for the patient, but it also makes financial sense for them as well. When I mentioned healthcare-associated pneumonias, this is really referring to people who've been maybe hospitalized in an acute care facility more than 2 days in the past 3 months. Very often it's going to be those that are in the nursing home or in a long-term care facility. If they are receiving chemotherapy, because they're coming into the infusion center to get their chemo frequently, so they're around that healthcare environment. They've gotten recent IV antibiotics, wound care, hemodialysis. These are people that are constantly in contact with a healthcare environment, and so again, they're at risk for picking up bacteria that have been maybe left by other people there, right? Some of these risk factors for nosocomial pneumonias we can't really do anything about. Like we can't make a patient younger, unfortunately, as much as they may want us to, or we can't necessarily affect their level of consciousness. If it's kind of their baseline, things like that. However, other things we can try to do would be to try to get rid of any sort of external devices for these patients. And what I mean by that is anything that's kind of like any foreign material being inserted into the patient, basically. So if you have a big plastic tube going down your throat into your lungs, that's a vector for bacteria to grow on that. They love growing on that plastic and can move on down and into the lungs. If you have an NG tube placed for a long period of time, if you have an ICP monitor, which is not monitoring for insane clowns, but is instead an intracranial pressure monitor, that is going to be something that is obviously a vector for bacteria to get in. Other things to consider too would be things like H2 blocker, antacid therapy. Now we're going to talk about GI drugs later on, but these are acid suppressing drugs. And normally the stomach is actually a pretty sterile environment because the pH is so low, because it's so acidic that no bacteria can really grow there for the most part. But if you put them on acid suppressive therapy, you're going to find that bacteria can start to grow, and then patients can have micro aspirations. Eventually, some of those bacteria get into the lungs. So these are all things we're thinking about and things we're going to try to get out of the patient as best we can, although sometimes you may not be able to, right, depending on the situation. So looking at our nosocomial pneumonia, what are the common etiologies here? So we're certainly going to keep gram-negative bacilli on the top of our list. Pseudomonas first and foremost. We're always going to include Pseudomonas in our empiric treatment, but we also want to consider other gram-negative bugs like E. coli, Klebsiella, Acinetobacter, all that good stuff. We certainly want to consider gram-positive cocci. We're going to put MRSA on the top of our list here as well, but keep in mind most of the things that treat MRSA are probably going to treat strep pneumo too. So that way we're going to cover two birds with one stone, so to speak here. And then, if you put patients on empiric therapy but they're not improving, like what's going on here? There could be something else, like maybe a fungal pathogen, right? Or maybe a mycobacteria or something like that. So we may need to consider fungal pathogens as well, especially those that are like really immunocompromised, like they're on chemotherapy and they're neutropenic. Like those patients are more likely to grow fungus and things like that. Obviously, it's really important to make sure they have good oral care. Make sure that their mouths are being kept very clean because it could be one big vector for bacteria that you can deal with right there. So for a patient you suspect has a nosocomial pneumonia, want to start therapy as soon as possible. You don't necessarily want to wait for a definitive culture. So say you have someone coming in from the nursing home, maybe no one's been keeping an eye on them for the past couple of days. They're dehydrated. They come in, they're really sick as all get out. Get your cultures right then, but you don't have to wait to find out what the gram stain is in order to start treatment. We're going to have good empiric drugs that are just going to cover pretty much everything. Okay. Alyssa's saying, sorry to go back, but how do you consider an NG tube / vent to be modifiable? Would you then add antibiotics to the tubes as an empiric treatment? It's a good question. So some of those things we consider them modifiable because as a provider, you get to decide when those come in and out. So you may have a patient who is sick enough to where they can't be removed. However, the goal is to get them removed as fast as possible. Okay. So that's one thing you always want to consider is when you're looking at patients and you're looking at things like, okay, they have a catheter in place, urinary catheter. Do they still need that or not? Because if they don't, get rid of it, because that's going to, one, help them get better faster, because it means they're they can urinate on their own, they can get up and get around, they may be closer to discharge. Again, the goal is to get them out of the hospital, because hospital is the worst place to get better because of all the bacteria that are growing there, and the risk for infection goes up the longer you're there, right? They have an NG tube in place. Can they eat on their own? Are they well enough to do so? If so, get rid of that NG tube. Don't leave it in there longer than possible. So from that sense, that's why we consider it a modifiable risk factor. However, you may just have patients who cannot be extubated because of the fact they just cannot breathe on their own due to mental status or respiratory failure, whatever the case may be. So again, it's not one of those things where say like, well, I don't want them to get a pneumonia. Let me go ahead and take this vent out and then they die. That probably wouldn't be a good idea, but that's how I consider sort of modifiable. So some, you're also asking, well, can you just give antibiotics to the tube as empiric treatment? We don't do that necessarily, but we do try to disinfect them as best as we can, or try to change them out as often as we can. So as an example, there is an oral sort of disinfectant we'll use, and this is part of like the oral hygiene that will be used for like ICU patients. the product called chlorhexidine or Peridex, and that's used to try to clean out the mouth and try to clean around the tube, so that way if there is anything growing on there, you go ahead and you deal with it like that. So disinfectants are used. Sometimes we'll change things out if we have a suspicion that they are infected or if they've been there for a while. So you may have like a IV line in place, and they can only be there for so long before we know the risk for infection goes up, and then we'll just change them out, for instance. So there's a lot of things that go into it that don't necessarily have anything to do with drugs, but you'll find out as you kind of get more clinical experience and are working out there. So good, really good question though. I like that insight there. So, and I love questions like that. I love going off on tangents. So the more you guys can get involved, I think the more interesting, hopefully it'll be for you all, as I hear me drone on my slides the whole time, right? Good, I'm glad that makes sense. Anyway, so basically what we're going to do is initiate that broad spectrum therapy. We're really going to consider also multi-drug resistant bacteria. That's an MDR, what that means. And they need to cover for MRSA and Pseudomonas. So at a baseline, considering these patients are going to have resistant bacteria, and they're also, we need to cover for MRSA and Pseudomonas. So we want to make sure that's our empiric therapy, and we'll look at specific drugs to do that. Once we have cultures and sensitivities back, at that point we can then start to streamline things and maybe take drugs off. So if my patient comes back and they're only growing MRSA, then you can remove everything except for the MRSA treatment, for instance, right? So how do we do this? Well, basically, if we suspect we have some sort of nosocomial pneumonia, and again, we look at risk factors. So do we think they have prior antibiotic use in their history? Are they on immunosuppressive disease? You know, things like that. Most patients that develop a nosocomial pneumonia are probably going to have risk factors for these multi-drug resistant pathogens. So most of them are going to get put down this pathway to get the broad spectrum initial antibiotic therapy. Relatively few patients that have a nosocomial pneumonia will fit the bill for this kind of limited spectrum, but we'll look at what that is. Basically, if they are having no risk factors for multi-drug resistant pathogens, and typically we'll see things like ceftriaxone or a third-gen cephalosporin get used most often. As an alternative, you could use something like levofloxacin or moxifloxacin. This would be more so if I needed atypical coverage. I thought there was like mycoplasma present or Legionella or something like that. And again, the classic thing for Legionella is like, oh, the patient was in a hotel and they were at a conference and the AC unit was busted and everyone got pneumonia, right? That's always like Legionella. It's like classically, you can look up the story of how they discovered Legionella in the first place, but the story similar to that, but that's always a popular board style question. So if you were to consider something like Legionella or mycoplasma, then using a fluoroquinolone makes sense because that'll get that. Remember, your cephalosporins, really no beta lactams are going to be able to get atypical pathogens. It's just not really in their wheelhouse. All other alternatives could be something like ampicillin sulbactam. Remember, it's a combo of ampicillin, a beta lactam antibiotic, plus a beta lactamase inhibitor, or something like ertapenem, which is kind of like a wimpier, more narrow spectrum carbapenem there. But most patients probably not going to fit the bill for this, and so we're going to require more broad spectrum therapy, right? So typically this is going to require 3 different drugs here, okay? I'm going to already tell you there's going to be a test question on this, most likely, where I'm going to ask you, okay, you have a patient who is at risk for multi-drug resistant pathogens with his nosocomial pneumonia. What is the most appropriate treatment here? I'll give you 4 choices of 3 different drug combinations, or maybe 2 drugs, maybe 4 drugs, but you need to figure out what's most appropriate based off of the mechanisms of the drugs, the classes of the drugs, based on contraindications for the drugs, etc. Figure out what's most appropriate, right? So here's how we do this. So first off, you're going to need combo therapy for your gram-negative bugs. This is mainly for coverage for Pseudomonas. Now, if you recall last semester, I told you don't really double cover for bacteria. It's not generally good practice. This is one of those rare cases where you do so. So you want 2 drugs for pneumonia, or I'm sorry, for gram-negative bugs here. So typically, it'll be some sort of beta-lactam drug, whether that's a cephalosporin, a carbapenem, or a penicillin. I'll get into the individual drugs here in a moment. So one of those, plus something from a different mechanism. You want a beta-lactam, a wall-active drug, plus something else like an aminoglycoside most often, or a fluoroquinolone. Okay, probably levo or cipro is most common, but I'll get into the individuals here in a moment. So you want 2 drugs for gram-negatives, and then you want a third drug for a gram-positive coverage here. So something like vancomycin most often, or occasionally linezolid. Okay. So if I put up a test question like that and I give you 2 beta-lactams plus vancomycin, that doesn't make sense because using two beta-lactams together is not good practice there. You want synergistic mechanisms here. If I put a fluoroquinolone plus an aminoglycoside, that could make some sense, but it's not the best choice because you still want a cell wall active drug there. So ideally, you're going to want either cephalosporin, carbapenem, or penicillin plus a beta-lactamase inhibitor. Again, I'll show you those examples in a moment. One of those plus aminoglycoside or fluoroquinolone plus vancomycin or linezolid. Those are like your most common combinations there. So getting to the individual drugs here, typically in terms of your cephalosporins, using your third or fourth gen cephalosporins is going to be kind of your go-to here. And again, when I say cephalosporin, I'm talking about Antipseudomonal cephalosporin, right? So just to make that clear. So like Rosefen's not going to fit the bill here. Rosefen doesn't really cover Pseudomonas at all, even though it's a third gen cephalosporin. You really have two options that are most commonly used. You have ceftazidime and then cefepime. Ceftazidime we don't use very frequently because of the fact that it gets resistance developed very quickly. So really, cefepime is going to be your go-to here. So if you're looking for a Antipseudomonal cephalosporin, this is the one you want to go with 9 times out of 10. Okay. Be aware, a lot of these require renal adjustment. And why do I make this point here? Well, because a lot of these patients with nosocomial pneumonias, they get really sick and they're at risk for developing things like sepsis, right? Or septic shock. If your blood pressure is not able to be maintained because you're going septic, your body's going to divert blood flow away from non-essential organs, okay? When I say non-essential, I mean all of your organs are essential, but in order to live, you at least need a brain and a heart, right? I can give you an artificial kidney. I can do artificial lungs. You at least need a heart and a brain. Brain most likely, right? I can give you an artificial heart. It can put you on like an ECMO machine or something like that. But primarily, the body's going to try to keep those two organs running, right? Which means things like the GI tract are going to take a hit. Things like the kidneys are going to take a hit. So that's why it's important because as patients get hypotensive, they're not going to perfuse the kidneys pretty well, which means they cannot clear these drugs as well. It means you need to look at their renal function and adjust for this because you could be predisposing them to side effects if you do not make sure they're clearing these drugs appropriately, okay? That's the main point here. A lot of these patients are very sick. They may have compromised renal function or already have pre-existing renal dysfunction. You got to adjust these drugs for that. Otherwise, you can lead to a lot of medical errors. And that's something I see very commonly when I used to round on the ICUs more commonly. You see this all the time. Patients do not, or providers do not go through and reassess renal function, which may change from hour to hour, day to day, etc. Right? So getting to the carbapenems, we're going to see here that the big ones you want to shoot for are either going to be like imipenem, cilastatin, or meropenem. Most hospitals I've ever worked at have just used meropenem as their go-to here, mainly because imipenem has a risk for seizures, especially in those who have a seizure history. So I see a lot of people sort of shy away from that drug. Meropenem really doesn't carry that risk there. And then ertapenem doesn't really have good consistent activity against Pseudomonas, so we wouldn't use that one there. But so meropenem is probably going to be the one you go with 10 times out of 10, at least at all the hospitals I've worked at. Again, it's not every hospital, but I've worked at a few. Again, this is another class of beta-lactam drugs that require renal adjustment. You kind of see the trend we're seeing here. And then we're going to find, in terms of Antipseudomonal Penicillins, piperacillin tazobactam. This is the one I see, again, the most common one I'm going to run into. My clinical experience, ticracillin clavulane is available, but I don't see that used as often either. And again, this requires renal adjustment. So the three big ones out of the beta-lactam drugs you want to focus on are probably going to be cefepime from cephalosporins, from piperacillin tazobactam from the penicillins, Antipseudomonal penicillins, and probably meropenem, right? So generally one of those three beta-lactam drugs is going to be that cornerstone for your therapy to cover nosocomial pneumonia, okay? And again, if all this sounds like Greek to you, you can go back and review the slides or ask any questions you have and make sure I can address that. In terms of fluoroquinolones, primarily what you're going to find is that Cipro and levofloxacin are probably the two most common ones you're going to go with here. They still have good coverage against atypicals, which is beneficial if you suspect that patient has an atypical pathogen present there. They also have really good lung tissue penetration. We're going to find that's a challenge with certain antibiotics is to penetrate the lungs. It can be difficult, and so that's why you may have to dose more aggressively for lung infections, because the lungs tend to be more difficult to get the drugs into, basically. I see a lot of patients or a lot of providers try to resist going to fluoroquinolones because of resistance. So if I had someone who had a really strong suspicion of atypical pneumonia, I would go ahead and utilize one of these, but otherwise I'd probably hold off. And again, remember these also require renal adjustment. Notice the trend here. A lot of these require renal adjustment, so that's why it's so important to look at. And again, something I like all my providers to look at, because otherwise it is job security for me to need to go back there and do that, but it's also not good for the patient if they don't have someone looking at that stuff for them, right? All right, and then we have the aminoglycosides. Typically, either gentamicin, tobramycin, amikacin. Any three of these would be fine here. Typically for this, what we're going to utilize is what we call once daily dosing for this, where we give really big doses up front, usually anytime during the day, and then that will allow for really good lung penetration. It also gives the body time to clear it out and get rid of the drug over that 24-hour period, so that way we don't get accumulation. As if you recall from last semester, having high levels of aminoglycosides building up can lead to ototoxicity and nephrotoxicity, which again, these patients may already have renal dysfunction to begin with. They don't want to worsen that with the drugs, so we want to make sure that we're monitoring for this, and this is one we do therapeutic drug monitoring on pretty frequently, okay? So most of the time, what I'll see for patients coming in for like a nosocomial pneumonia, you'll either find typically like a cefepime, piperacillin tazobactam. Those are kind of the two most common. Usually we try to hold off on meropenem because we save that for like the really resistant bugs. And then typically an aminoglycoside, right? More often so than I would see a fluoroquinolone, but aminoglycoside here because they just have really good synergy and they typically get the job done for most patients. And then for your MRSA coverage, this is where vancomycin is going to be used probably 9 times out of 10 for the most part. This is another one we have to do therapeutic drug monitoring on and make sure that the levels are high enough, because remember, this is a time-dependent antibiotic, so the levels drop below the MIC, you're going to find it does not inhibit that bacteria anymore, the MRSA. And again, we shoot for higher troughs here because of the fact that vancomycin is a very big molecule, has a hard time penetrating that lung tissue. And so that's why I have to shoot for higher levels for it. Now, am I going to ask you necessarily what the gold trough is? No, but I may ask you questions about what we need to do if the level is off, right? So I may say, okay, well, here's the goal level, 15 to 20, and here's where they're at. What do you want to do about that, right? If it's too high, then obviously you want to do things like either lower the dose or extend how often you're giving it. Because again, this is nephrotoxic in addition to the aminoglycoside that they're on, in addition to the septicemia they have that's causing hypotension, leading to renal dysfunction. So all these things can compound on one another. So it's very easy to see how this can happen. It can kind of snowball. And so it's important to be able to kind of interpret levels and to be able to say what to do next about it. Okay. So things like that. So for instance, if I ask you a question, say, okay, well, patient has a level, they're getting vancomycin 1 gram every 8 hours, and their trough comes back at 25, and their goal is 15 to 20. What do you want to do? Right? Obviously, you don't want to increase the dose. Obviously, we don't want to give it more frequently because that would just lead to a higher trough. Maybe you could say, okay, well, decrease the dosing and we'll give it every 12 hours instead. And then recheck a level once it hits steady state. So little things like that, I'd like you to be able to interpret those levels and more so than trying to just memorize them. Okay. Now, if you had someone who had like really poor renal function, or someone who had maybe a vancomycin resistant bacteria, this is where you can bust out your linezolid. This is nice because it has really good pharmacokinetics. It penetrates the lungs very well. Does not require adjustment based on renal function, so it's kind of a unique thing there. However, it's pretty expensive, and we typically will hold off on using this due to trying to prevent resistance. So vancomycin is going to be your first line coverage for MRSA, probably 10 times out of 10, and then rarely will you utilize Zyvox first line. So, but it's a good alternative. They cannot take vancomycin or they become resistant to it. Okay, so that's kind of empiric therapy. So you'll start the patients on that, and hopefully they're going to improve. Their fever is going to come down, white count's going to come down, blood pressure stabilizes, etc. Right? Once those cultures come back too, then you can kind of scale it down. So let me ask you a question like this too, saying, okay, well, the culture comes back and it's MRSA. What do you want to do? Well, you probably don't need antipseudomonal coverage if they're just growing MRSA, right? And the patient's clinically improving, then yeah, go ahead and take off the other stuff and just leave the vanco on for now, right? If it comes back and it's, for instance, something like MSSA, well, then I don't really need vanco either. I could just go ahead and scale down to something like nafcillin or dicloxacillin or something like that, right? So I want you to kind of think about what you do based on these results here, and I'll give you some more examples as we go along. So just something to consider. What to do if patients are failing therapy? Well, you have to consider maybe it's the wrong drugs, right? Maybe I did not give adequate enough antimicrobial therapy in the first place. Perhaps there are resistant pathogens there that I need to try to step up my game. Perhaps, you get a Pseudomonas that comes back resistant to piperacillin and tazobactam, so then you have to scale it up to meropenem, for instance, right? That could be something to consider. Sometimes it's the wrong diagnosis, so maybe it could be cancer, it could be a pulmonary embolus they're actually dealing with, and then also consider kind of secondary complications. So by blasting these patients with really broad spectrum antibiotics, you run the risk of things like C. difficile, secondary lung abscesses, all kinds of problems that can pop up here. So just little things to consider. Typically for patients, we'll treat for 7 to 8 days, but it may be longer if it's especially more kind of sinister bacteria like a Pseudomonas or something like that. So again, I'm probably not going to ask you like specific durations of treatment, but this is an idea of how long they'll be on therapy for. So any questions on that so far before I get into the kind of second piece of this? I don't see any questions up on the board. I assume otherwise, if I don't hear any questions, then I just assume I'm teaching everything perfectly, which I know is not the case. Nobody is perfect, as it turns out. But anyway, so getting into talking about asthma. So this is another kind of really common thing you're going to run into with your patients here. This is basically going to be a reversible narrowing of the airways. We're going to see that this is something to where when treating asthma, we're going to see, and most of you are probably familiar, like kind of what asthma is, and have probably known someone or seen someone or been someone who has asthma. We're going to see here is that there's kind of two modes of therapy for asthma. There's going to be sort of like chronic management and trying to prevent asthma exacerbations from happening, and then acute treatments for asthma exacerbations. You want to kind of think about this in two kind of modes, either acute treatment or prevention. You'll see this come up a lot when we talk about things like migraines, seizures, etc. As we go down through the semester here. But basically, they're having a lot of inflammation that's leading to this airway hyperresponsiveness and obstruction. That's where you get the wheezing, the coughing, the mucus production, difficulty breathing, all of that stuff that comes from asthma. And this is an issue of inflammation. We're going to see that the cornerstone of therapy in a lot of cases is going to be trying to deal with that inflammation. We'll have several ways that we can do that. Just to give you an idea, IgE is going to be the major player here in terms of activating and causing degranulation of a lot of your granulocytes. And when they do degranulate, they release a lot of those inflammatory cytokines, things like histamine, things like tumor necrosis factor and leukotrienes and prostaglandins, all kinds of stuff. We're going to see this sort of same pathway come up again and again. We talk about like rheumatology and all kinds of different stuff. But this is primarily what we're going to focus on here. If we can do things to try to either inhibit the activity of these inflammatory cytokines, or if we can try to prevent these cells from degranulating in the first place, that's all going to help to prevent our symptoms from happening overall, right? And again, you're going to see there can be immediate sort of acting substances, but there's also going to be things that happen over the course of hours, and this can lead to some of the more prolonged sort of bronchospasm you'll see in these patients. Which makes sense if you imagine like an actual asthma exacerbation happening, which could be sort of evidence in their changes in FEV1, a forced expiratory volume over 1 second. You'll see that it dips down early as you get sort of initial release of inflammatory cytokines from those degranulated mast cells. And then over time, things may get better, but then as the cells are producing all these extra cytokines, you'll have kind of a delayed reaction here that can happen. So we want to make sure that we can treat both the acute early phase here, but also this delayed phase. And so we're going to see different medications that are beneficial for all those, okay? And just imagine what this looks like in terms of allergen causing things like T cell activation and cytokine production. You can see what it would look like with a normal bronchus versus with the asthmatic bronchus. Notice there's mucus here. The muscle is thickening. You're seeing. You can imagine it's very, very easy to imagine having a hard time moving air through those occluded bronchioles because again, the radius is getting much smaller. That really decreases the amount of flow that you can have there. That's where you get a lot of that wheezing and all of that, right? So another thing I want to look at too is, if you recall, we talked about NSAIDs at least to some degree last semester. But remember the arachidonic acid pathway, how this happens when some sort of inciting event causes inflammation to occur. Arachidonic acid gets liberated from the cell membranes. It can kind of go down two pathways here. We've talked about the cyclooxygenase pathway in terms of like pain and fever and things like that. And this is where our NSAIDs work. We're not going to focus on this so much, but we're going to focus more so on this 5-lipoxygenase pathway. This is a pathway that ultimately leads to leukotriene production. So if you say LTA4 or LTD4, these are leukotrienes, and these are substances which help to increase that bronchial hyperresponsiveness. This is what causes that bronchoconstriction to occur. So for asthma purposes, we're going to focus on this side of the pathway here and ways we can try to inhibit this as well. I'm introducing all these things here because I want you to think about ways that we can try to interrupt this process with medications, right? So, as I mentioned, usually the pathogenesis for asthma is coming from some sort of allergen. So whether it be from pet dander or could be even cold air, not so much an allergen necessarily, but it could be just as a trigger for hyperresponsiveness. Something is causing some IgE production to happen here. And again, that causes mast cells to degranulate, releasing all of these nice inflammatory cytokines. So primarily we're going to see things like leukotrienes here, histamine, all that leading to bronchial smooth muscle constriction, mucus production, etc. Right? And again, once those mediators start releasing, or once all those mediators are released from the mast cells, you're going to find that, especially with re-exposure, can lead to even more acute bronchoconstriction and vascular leakage, right? So this is kind of that early response we see there. Patients ultimately start complaining of like chest pain, or they get wheezy and all of that. And then it's the longer phase that oftentimes can be proved to be more fatal for patients who die from asthma. Now, it's not common to see patients die from asthma, but if they do, it's more often this late phase because you get more kind of a long-term, stronger constriction of that bronchial smooth muscle here. And so we'll see ways we can try to treat this for the delayed phase and ways we can try to treat that acute phase. Okay. As I mentioned, most of the times it's an allergen causing this, but it could be illness. It could be cold air. That's why you see, especially in like winter months, you'll see some people require more use of asthma treatment and things like that. You know, and even in some cases, we can actually induce an asthma attack. There's some means we actually have to diagnose asthma by giving people a drug that specifically causes that bronchial smooth muscle to constrict, and people that are really sensitive to that are more likely to have asthma. And so there's actually a drug we can use there called methacholine. We'll sometimes use this in like research studies to induce an asthma attack, and if we see their FEV1 drop down significantly, then that shows us they probably have hyperresponsiveness and they probably have asthma, as opposed to someone who does not have asthma would not have that big of a drop in their FEV1, for instance. Anyway, so the bronchoconstriction here is going to happen via a couple of different pathways. Some of this is going to be due to like vagal receptors being activated here. Some of this is due to some of our neural or humoral pathways. And we're going to see, this is the big thing to take away here. Asthma can be treated with drugs with different mechanisms of action. Okay, I'm going to bold that because you want to know what drugs you're using, how they're going to work together synergistically, and how to use them for either for acute treatment or for prevention of asthmatic symptoms. This is what I want to focus on here, right? A big thing you'll see, and you probably noticed this from last semester, is I want you to know how to use different drugs together synergistically, because it's very often patients are not treated with just monotherapy, but you want to know how the different drugs work together, and you don't want to double up on things, because using two drugs with the same mechanism doesn't make sense. It doesn't get any additional benefit, and probably just increases risk for side effects. So, a couple of things we can do here. First off, we can reverse acute bronchospasm. This is going to be our acute treatment for asthma exacerbations. This is going to include our beta-2 agonists, anticholinergics like ipratropium and theophylline, right? We can try to remove the trigger of the antigen. This is going to be done less frequently, but I'll cover these very briefly here because they don't get used clinically all that often. And then we can try to control the inflammation. This is where steroids and our lipoxygenase inhibitors are going to come into play here. These are going to be good for prevention of symptoms in the long term. These are going to be good for acute treatment of symptoms in the short term. Okay, try to keep that in your mind. I talked about that FEV1, the methacholine challenge, where you can actually try to diagnose asthma in a patient. Most of the time, you don't need to do this. You can just do it based off of history. And honestly, if you have a patient who comes into your urgent care wheezing and you give them a albuterol inhaler and they get better right afterwards, then you probably know they have asthma. They have some degree of bronchial hyperresponsiveness. But you can do this occasionally, especially in like pulmonology or research. You might do this. Okay, So in terms of the asthma, you can break it down in terms of the symptom severity and also how intermittent or persistent it is. I'm not going to ask you this specifically, but you'll probably get this in your other classes in terms of actually having a diagnosis, having someone with like intermittent or persistent, moderate persistent asthma. I'm not going to quiz you on that specifically, but just realize that patients who only have intermittent symptoms maybe maybe treated differently than someone who has more persistent symptoms. And even within the persistent people, you may require different or more medications in order to help keep them under control, right? So some of the questions I may ask you though will be like, okay, a patient's currently on this drug. Here's the symptoms they're having. They're obviously not well controlled. What do you want to do next? So we'll talk about some options there in terms of going these stepwise approaches in order to help control patients' asthma symptoms. All right, so our goals here are basically trying to reduce that bronchial responsiveness in the long term. So we want to deal with that airway inflammation and try to utilize anti-inflammatory agents to help control that. That's where our inhaled corticosteroids are going to come into play here. And then, so again, that's long-term goal. And then we also want to help deal with reversing acute bronchospasm. So this is either try to avoid the allergens. So for instance, I know if I go around cats, I'm probably going to have an asthma attack. It's just, that's the way the world works. The sun rises in the east, sets in the west. And me and cats are mortal enemies, right? I kind of like cats, but they certainly do trigger my asthma. We're going to treat these mainly with beta-2 agonists, but we'll also see a few additional agents that we can use as well. So this is a good slide to sort of break down these drugs into their different categories. We have quick relief drugs and we have long-term controller medications. You need to know how to use these effectively, because if you try to use one of these in the wrong situation, it's not going to be very beneficial, right? And so I always have students who have a tough time with this, and there'll certainly be questions about this. I'll say, what's good for long-term control of asthma symptoms? And they'll put down a short-acting beta-2 agonist. Like, well, that doesn't work that way because it's a short-acting drug. It doesn't do things long-term. So try to keep these in mind as we go through the drugs and kind of realize why we're using them, how we're using them, and that will make more intuitive sense. I don't want you all to necessarily memorize this list, but I want this to make intuitive sense based off of what you understand about the drugs once we talk about them, okay? We'll get into that more so later. So the cornerstone of quick-acting treatment for asthma is a beta-2 agonist. Basically, you have beta-2 receptors that are kind of lining the lungs, and when you activate those, they increase cyclic AMP, which is a secondary messenger we talked about last semester, that causes smooth muscle relaxation. So this is ultimately what they do. They relax the airway, smooth muscle, by activating beta-2 receptors, okay? So we can have either long-acting beta-2 agonists, which are good for kind of long-term control of asthma symptoms, and we can have short-acting beta-2 agonists. Short-acting beta-2 agonists is like that typical albuterol inhaler you always think about. Kind of common side effects you're going to find is that while these drugs are called beta-2 agonists, they can also have activity on other receptors as well. They don't just work in the lungs, but they can work on the heart, they can work on skeletal muscle. So it's common that you're going to see things like tremor associated with these drugs, and also you're going to see increased heart rate. So tachycardia is a very common side effect of beta-2 agonists. Tremor is pretty common too. A lot of this is going to be based on the drug you're using and the dose and things like that. We'll talk about that more in a minute. So here's just a picture of how you might imagine that. This is a smooth muscle cell within the lungs. By activating beta-2 receptors, this allows for this inhibitory action of cyclic AMP, and allows for the actin and myosin to relax from one another and causes this to relax, opens up, and allows the bronchioles to open up and allow more air through. A very good thing that these beta-2 agonists do for us. So in terms of short acting, the benefit here is we don't have like a ton of different agents here, so it kind of keeps it simple from that standpoint. The sort of gold standard for short acting beta-2 agonists is albuterol. There's a lot of different brand names: ProAir, Ventolin. You can find it in different dosage forms. Most often you'll see it as the metered dose inhaler, so an MDI. It's a typical sort of canister that they'll squish down and cause the gas to be propelled out. You may find this in a nebulizer, for instance, so different ways you can see it being used. There's also an enantiomer of albuterol called levalbuterol. It's basically the left-handed form of albuterol. It's called Xopenex. Some people feel that they have less side effects associated with that. I think you can there's way you can get around it. Some people swear by it, and so you'll find most hospitals don't carry it because it's a lot more expensive, and most people do well with albuterol. But you'll have some people that say, no, this is the only thing that works for me. And I say, okay, that's fine. So either of those are good as short-acting beta-2 agonists. Most people are probably going to be fine with just using albuterol. For the long-acting form, and again, these are going to be drugs you do not want to use by themselves for asthma. We actually find that they can actually increase mortality if you're using by themselves. But we'll see some combos we can get away with here in a few moments. This includes formoterol and salmeterol. Okay. Notice here you can kind of tell by the name if it ends with like a all, then that's probably going to be one of these beta-2 agonists. So hopefully that helps out with memorizing what they do. But you still want to make that distinction. You don't want to sub in albuterol for formoterol and vice versa because you're not going to get the same clinical activity, right? The adverse effects I mentioned, this is all related to either having direct beta-2 activity, or you can see sort of like crossover the beta-1 receptors and lead to some of these side effects here. A lot of this has to do with dose. Now remember, these are mainly going to be inhaled drugs we're talking about here, which helps to limit where they're working at, so that way you get mostly just lung activity, which is good. But we can see some systemic bioavailability, which means you can get systemic effects from this. You're going to see this with bigger doses, especially if patients are getting this via like a nebulizer, where they're getting just huge amounts of the drug being puffed into their face and they're breathing it in passively. You're more likely to see side effects than if you're just using a regular meter dose inhaler here, right? I don't know if I have any respiratory therapists in the class, but if so, if you have any thoughts, feel free to pop in. I have those every once in a while, but I forget in this class if I do or not. But I've had asthma all my life, and I remember whenever I would have like a respiratory illness growing up, I would always have to bust out the nebulizer, and I'll talk more about dosage forms here in a minute. But I would always have to like breathe in these like really massive doses, and I felt so jittery afterwards because of the beta-2 agonist working on the skeletal muscle, causing tremor. I remember feeling my heart racing, feeling kind of lightheaded and dizzy just because you're getting so much of it. You won't see this as often if you're just using a regular meter dose inhaler because the dose is much smaller. You're less likely to get systemic effects. So a lot of this is very dose dependent. There's even like an oral form of albuterol some people have used in the past, and that stuff is like terrible for side effects because all of it gets systemic before heading to the lungs. There's a lot of side effects you can see with that. All right, so that's for in terms of like quick acting therapy, albuterol, levoalbuterol, that's where it's at right there, right? Getting into more of the controller medications, we're going to have our inhaled corticosteroids, or ICS, if you see that term. This should look familiar to you if you recall the ENT lecture where we talked about nasal corticosteroids. Now, some of you may have repressed all those memories because they're so traumatic for you, but I'm sure you still have the PowerPoint somewhere. Go back and take a look at that list and compare. But note here that we have all the same corticosteroids. It's just the dosage form has changed. Instead of being a nasal spray, now it is an inhaled form here. So the goal being to get the drugs straight to the lungs where they work locally, instead of having to utilize systemic corticosteroids. So the side effect profile is going to be much better for these than you would see for a systemic corticosteroid. So you're never going to see someone with asthma being treated chronically with something like dexamethasone or prednisone, but you will see them being on these inhaled corticosteroids chronically, perhaps for years, perhaps for life, depending on the situation. But things like beclomethasone, budesonide, flunisolide, fluticasone, mometasone, and then triamcinolone. And note here the brand names, they try to kind of give you an idea if it's the inhaled form versus the nasal form. So for instance, Flovent versus Flonase kind of makes a sense if you kind of look at the kind of the constituent parts of the word there. Pulmicort versus Rhinocort. You can kind of intuit that if you know what the prefixes mean there. So I mentioned this because it's very common for these drugs to get mixed up. It's a common medical error. You write for fluticasone for someone with asthma, and then all of a sudden they get a nasal spray, which they may not require. So just be wary of that. Make sure you're specifying, hey, fluticasone inhaled steroid, or fluticasone inhaler or Flovent as a means of differentiating from the nasal spray. So the inhaled corticosteroids, they help to inhibit the inflammatory cascade, and these are very powerful at doing so, but it's a slow process, right? Because corticosteroids work at the site of the nucleus to prevent things like gene transcription and whatnot. So they can take up to 6 to 8 weeks really to get maximal effects there. So this is why patients have to take it consistently. Otherwise, they're not going to get the benefits. And as soon as they stop taking it, the benefits go away fairly quickly. I mention this because patients can have cycles of their asthma where they may, not have any asthma attacks for a while and they feel good. They haven't had to use their inhaler for a bit. They say, well, maybe I'll stop taking that inhaled corticosteroid. And so they become non-compliant, and all of a sudden their asthma comes back. They don't realize the benefits of the drug while they're taking it in terms of them not needing to use that quick-acting beta-2 agonist, right? So this is why you need to really tell them, hey, you may not feel like this drug is doing anything, but it certainly is. Make sure to keep using it consistently, because otherwise you'll see these asthma attacks start to become more common or more frequent. Now, some things we are concerned about in terms of side effects would be one, the fact that when you're inhaling these drugs here, note that not every particle of that drug is going to get into the lungs, right? If you imagine sort of the anatomy of the oropharynx, you're going to see that some of the drug is going to get deposited on the back of the throat. Some of it's going to get swallowed into the GI tract, and then some portion of it's going to get into the lungs where we want it to go, right? And again, patient technique is going to be so important for their ability to use these drugs effectively, that they may have really poor technique and maybe most of the drug ends up in the stomach or most of it ends up in the back of the throat or something. So I'll talk about technique a little bit later on here. But basically what you're going to find is that in terms of adverse effects, you can see with patients utilizing inhaled corticosteroids, some of that drug is going to get deposited on the back of the throat. That can lead to a local immunosuppression, and that can lead to thrush, right? Normally see thrush in patients is a sign of immunosuppression, either due to like HIV/AIDS, cancer treatment, or something like that. But in this case here, it's due to their corticosteroid use getting in the back of the throat. So that's why we always tell them this is really important patient education. Wash out your mouth after using the inhaled corticosteroid. Okay, rinse out the mouth, gargle, spit it out, then you're good to go. Should help prevent any of that thrush and the little candida from sitting there and growing as a result of that local immunosuppression. There could be some risk for having things like growth suppression in children or inhibiting the immune system, but this would be seen more with like very high doses and really poorly controlled asthmatic patients. Now, I mentioned that it's not a good idea to combine your, or not to use long-acting beta agonists by themselves in asthmatic patients. But what you can do is mix a long-acting beta agonist plus a corticosteroid. And there's been a few more that have come out since then, since writing this, but these are some of the common ones you're going to run into. So this is the benefit of using a long-acting beta-2 agonist, which will provide benefits pretty much immediately as they're using it and provide sort of 12 to 24-hour broncho relaxation, in addition to a corticosteroid, which may take 6 to 8 weeks to work. So you get the benefit of something working a little bit sooner while you're giving time for that corticosteroid to kick in. And so this is a very popular combination therapy a lot of patients on. Some providers may just start them on an inhaled corticosteroid first. Some people may do the combination. Just depends on the provider and the patient, kind of what their symptoms are like. So this combo is okay for asthmatic patients. Do not use long-acting beta agonists by themselves. Can use inhaled corticosteroids by themselves. Just know that they won't really see a lot of the effects until several weeks into utilizing the drug. Okay. So some other ways we can try to inhibit the inflammatory process would be with our leukotriene modifiers. And this is basically trying to block the activity of the leukotrienes that we've produced through that arachidonic acid pathway. The main one you're going to see here is going to be montelukast or Singulair. This is going to be a direct LTD4 antagonist, so blocking that leukotriene from activating things like inflammation and bronchoconstriction and whatnot. May see this being used occasionally in patients who develop aspirin-induced asthma. Basically, aspirin in some patients can shunt that arachidonic acid pathway from producing a lot of prostaglandins over into producing leukotrienes. And so if you ever hear about someone have like an ibuprofen allergy or an aspirin allergy that gave them an asthma attack, this is probably what this is. It's shunted all of that arachidonic acid from producing prostaglandins into producing leukotrienes, which induce an asthma attack. So you see that occasionally. There's another one here called Xyluten or Zyflo. This one's not used too frequently. This is instead of blocking the activity of the leukotrienes themselves, will just block the actual enzyme itself. So this is going to be have a lot more side effects associated with it. It's a lot more expensive. And so we're going to see here that we don't really prefer to use this. Most patients will do well with montelukast. And again, it's very well tolerated for the most part. There has been some issues of like altered mental status for some patients, but for the most part, Singulair is very, very minimal in terms of side effects for most patients. It's very well tolerated. Also, probably not going to be as effective as something like a corticosteroid. So, you may see this as like an add-on to that for prevention of asthmatic symptoms, but is not going to be utilized. Rarely would be utilized by itself, and at least from my experience, what I've seen, and rarely going to utilize Dilutin because, again, in addition to having needing to be like injected and having issues like flu-like syndromes and sip interactions, it just doesn't get used very often. But you may see it occasionally, so it's good to know what it is. And again, here's that idea of either by inhibiting the LTD4 directly, where montelukast would work, by inhibiting 5-lipoxygenase, that can also help to reduce how much you produce at all, right? So kind of two ways to treat that. Again, this is the least common way to do so is by blocking 5-lipoxygenase. We just go ahead and just use montelukast singular and block the LTD4 directly, and it works pretty well. So in terms of side effects, again, a lot of stuff is mentioned here, but for the most part, it's very well tolerated. You're going to find most patients have no issues with taking their montelukast. And again, in terms of overall efficacy, it's fairly wimpy compared to a corticosteroid, but maybe a useful add-on. There is an idea that you produce more leukotrienes at nighttime. So for patients who have more like nighttime symptoms, this may be a good way to utilize singular. You'll see it dosed a lot of times at night in order to help prevent some of those symptoms from extra leukotrienes being produced due to your circadian rhythm producing them more at nighttime. So just something, if you ever see that, that's why that is. So you could try to remove the trigger of the antigen. So we have a few drugs here called mast cell stabilizers. I'll tell you, I've never actually seen these being used for chronic asthma. They don't do anything for already active asthma attacks because you've already degranulated those mast cells. And overall, in terms of preventing symptoms, they don't do as good of a job as the inhaled corticosteroids and long-acting beta agonists here. So overall, I wouldn't really spend a whole lot of mental headspace for memorizing these. Just know that we don't use them all that often, but if they do work, it is by preventing those mast cells from degranulating, basically. Also note they have to be taken pretty frequently, and they take a few weeks to kick in as well. So again, if you're going to be spending this much time and effort into preventing asthma attacks, I'd rather just use an inhaled corticosteroid. But you may use these as like a rare alternative if a patient maybe is not a good candidate for an inhaled corticosteroid, perhaps. But again, I don't hardly ever see it there. In terms of side effects, again, nothing all that too bad in terms of side effects. You may see some throat irritation and things like that, but for the most part, well tolerated. This is just stuff kind of listed in the clinical trials and whatnot. Okay, here's another one. So this is a good one for patients that have like really difficult to control asthma that maybe even maximize doses of inhaled corticosteroids and long-acting beta agonists, they still are having excessive asthma symptoms. This is where you can use something like Xolair or omalizumab. So just by the name, you can tell it's a monoclonal antibody. And this is actually a recombinant antibody that we've designed to attack and neutralize IgE. We saw before the IgE is the antibody that frequently causes the asthma attacks to occur. So if we can neutralize that, then that could be one way to prevent these asthma symptoms from happening here. So bind IgE and prevent those mast cells from degranulating. So I see this, we do this all the time, at least in our peds pulmonology clinic, but this is for the most severe cases of asthma that are not controlled by other things, right? Now, in terms of adverse effects, because it's a monoclonal antibody, there is a risk for having an allergic reaction to that protein that you're injecting. So one, it has to be injectable. And again, most of our patients at least come into the clinic to have to receive it from the nurses, so it can be troublesome from a logistical standpoint. But they also run this risk of having anaphylaxis. So you do want to make sure that you're monitoring for that and can treat that appropriately if it does pop up. There's some risk for secondary malignancies, but again, I don't think we know the full extent of that. So it's just something to think about. And again, this is going to be something that's also very expensive due to the fact it's a monoclonal antibody. So this is, again, reserved for those that are kind of failed everything else and you need something else to try. This maybe that. So kind of the last line therapy. As I mentioned, a lot of injection site reactions. You can see bruising around the site, itching related to that, and then anaphylaxis, while it's rare, it's still something you want to keep in the back of your mind. That's why we have them come into clinic to receive it in case they do have a reaction. Okay, so next we have our methylxanthines. I'm going to mention these now because they're going to come up in COPD, but we used to use these more often back in the day for asthma, but now it's pretty rare due to kind of adverse effect profiles for some of these meds. The big one we're going to talk about here is theophylline, or the IV form is called aminophylline. back in the day before we had inhaled corticosteroids, we didn't have a lot of good means of treating or trying to prevent asthma symptoms from occurring. So this is kind of what we had for a really long time. You'll see rarely patients will still be on this, but I've still seen it used occasionally for very severe asthma exacerbations in the ICU, for instance. And actually, some of you may actually be utilizing a methylxanthine yourself if you're consuming coffee or perhaps even chocolate this morning. That actually has methylxanthines themselves. So caffeine is a methylxanthine. Theobromine found in chocolate is a methylxanthine, and so is theophylline. And basically, they work by inactivating the phosphodiesterase inhibitors, and that actually allows for smooth muscle relaxation. So by blocking phosphodiesterase, it relaxes the smooth muscle, allows for better breathing to occur there. And we don't like these as much as the long-acting bronchodilators like corticosteroids because we find that overall they're less effective and then less well tolerated. So you're saying, well, why are you talking about it now? It does come up in COPD later on. You may find some very old patients who are being treated by very old providers who have been on this for decades, and this is just what worked for them, and they're going to be on it for forever. The problem you run into is it has a narrow therapeutic index, which means you have to do levels on it to make sure the levels don't get too high. If they do get too high, then you run the risk for things like arrhythmias, convulsions. Very nasty. I've seen a few patients have died from inadvertent theophylline overdoses just due to the fact that their renal function went down over time. No one addressed it. And they died from basically just accumulating too much of the theophylline, causing seizures and arrhythmias. It was pretty sad cases. Again, you may, in terms of reversing bronchospasm, theophylline nowadays is really relegated to COPD patients more so than asthma, which we'll talk about here in just a little bit. And again, by inhibiting phosphodiesterase, you're going to find that helps to increase cyclic AMP, increase the cyclic GMP, and that allows the bronchial smooth muscle to relax. Probably also has some anti-inflammatory actions as well, and by blocking adenosine, that leads to some additional bronchorelaxation. So a couple of different mechanisms here, but again, not favorable in terms of profile of side effects and efficacy, so not used that often. You can see here that some of the different side effects you're going to run into. So I mentioned with elevated levels, you can see convulsions and seizures, arrhythmias. So you really got to be cautious with this one to make sure you're checking renal function routinely to make sure that patients are not going to have issues of accumulating the drug. Just to give you an idea, I'm not going to ask you to memorize levels specifically, but you can see here that a therapeutic level is between 5 to 20, and once you start to get even to the upper range of that, you're already going to start to see some of the cardiac effects from the drug. So again, very narrow therapeutic index. Even level going up 30 to 40s where you can see seizures. It's very easy for patients to accumulate this if they get sick and dehydrate and the renal function decreases. So very nasty drug from that standpoint. Okay, so another class of drugs here we have are the anticholinergics. So these are basically blocking acetylcholine on the muscarinic receptors in the lungs. And if you think about the activities of the parasympathetic nervous system, normally we would cause bronchoconstriction by the actions of acetylcholine on those muscarinic receptors. We're going to block that and cause bronchodilation to occur here. And we have two different drugs that fit into this category. We have both ipratropium, which is the brand name Atrovent, which is a short-acting med. And then you're going to have a long-acting one called tiotropium or Spiriva, and this is going to be for COPD only. You'll see ipratropium being used occasionally along with albuterol for short-acting treatment of acute asthma exacerbations, and probably not so often on the outpatient basis. Most patients just get prescribed albuterol inhalers. But on an inpatient basis, like an ER, the urgent care, we will frequently use this as an adjunct in addition to albuterol to get some additional bronchodilation. So if you ever worked in like an ER somewhere and they say, okay, give them a Duaneb. Duaneb just refers to a combination of albuterol and ipratropium. If you ever hear give them albuterol and Atrovent, Atrovent is ipratropium there. It's that combo where you're getting from both a beta-2 agonist and an anticholinergic. Okay. Spiriva we'll talk more about when we get into COPD. Basically just a long-acting, 24-hour or more acting anticholinergic to help alleviate bronchospasm by blocking acetylcholine. Now, some side effects you can get from this, which is less rare or more rare due to the fact that it's locally acting in the lungs, but something I just like to refer back to is the anticholinergic side effects you could be getting if maybe you're using excessive doses, for instance. And this is the mnemonic I use. I probably covered this before, but this is a good mnemonic for anticholinergic side effects. This applies to any anticholinergic drug, whether it be diphenhydramine, whether it be some of the psych meds we're going to look at later. So this is handy to remember. So again, they get blind as a bat, meaning they get mydriasis and blurry vision. They get mad as a hatter, meaning have altered mental status, hallucinations, psychosis in some cases, worsened dementia. They get red as a beet, which I don't know. That's the kind of beet you drop, not the kind of beet you eat. So red beets would be like the flushing get there. They get hot as Hades, meaning they get fever, hyperthermia, dry as a bone. So everything dries out. So dry mucous membranes, urinary retention, dry eyes, and then say the bowel and the bladder increase their tone, meaning you're going to get constipation, urinary retention, and then the heart runs alone. So you can see tachycardia and hypertension. A lot of effects from this. You're probably not going to get a ton of them just from locally acting drugs in the lungs. However, high doses could cause this, and a lot of other anticholinergic drugs do these same things here. So I just mentioned it in terms of helping to kind of jog your memory, and remember that because it'll come up later on this semester. Okay, so that's all well and good. What do you do for like a really severe acute asthma exacerbation where maybe a patient's coming to the urgent care clinic, the ER, and their asthma inhaler's not been working for them, their albuterol inhaler? This is where we get into systemic corticosteroids. Systemic corticosteroids have no role for long-term control of asthma symptoms, but they're very good for in the acute phase if their normal short-acting meds are not going to work. So again, these are typically oral, they're IV. They help out, suppress, and control that inflammation. They do take some time to work, a couple hours probably, but they help out with that delayed phase of the asthma exacerbation as well. Okay. Again, we like to limit how long they're using these for because of all the side effects that we've talked about previously. We'll talk about them again here. So typically, a lot of patients will get maybe like a 5-day course of this. 5 to 7 days of steroids, and then they should be good to go from that standpoint. But this can include things like prednisone, which is the liquid form of prednisone, methylprednisolone, which is a common parenteral form, so for IV administration, or you can use Decadron. These are probably the 4 most frequent ones that we run into for asthma control, asthma treatment, basically. The reason why we don't like these for the long term, and certainly, yeah, you could take oral prednisone every day, and that would probably prevent asthma symptoms here, but then you have to worry about all these other issues here. So things like hypertension, growth suppression, adrenal suppression, right? Especially if you're taking steroids for more than a week, your adrenal glands start to shut down in terms of corticosteroid production. You get immunosuppressed, you get more likely to have infections. So this is why we do short courses. 5 days, you're generally good. We found some cases where, longer acting ones like dexamethasone, we can do like 2 doses, a day and a half apart, and that covers them for 5 days. So there's different ways to do it, but they all basically are being used for short term to treat that acute exacerbation. So looking at this, you can kind of see the stepwise approach you can go through in order to help manage these patients here. So if they have, just really intermittent asthma, maybe it's only when they go work out or they go run or when they get around a certain allergen, maybe they only need a short-acting beta agonist. That's what SABA stands for there. They only need an as-needed asthma and albuterol inhaler, and that's fine. Once you start to get persistent asthma, this is where you need a controller medication in addition to a short-acting beta agonist for acute treatment of asthma symptoms, right? So if you see ICS, it's inhaled corticosteroid. Most patients will probably get started for more mild cases with just a low-dose inhaled corticosteroid, okay? What do you do from there? Typically is where you start to consider adding on like a long-acting beta agonist, or you could try going up on the dose of the steroid, or maybe you could try something like a leukotriene antagonist, okay? But again, the most bang for your buck is going to come from the steroid, long term, and also the long-acting beta agonist. That combination of the two there is probably going to give you the most bang for your buck. And you can consider additional things like a leukotriene receptor antagonist, like Singulair, for instance. For the really severe cases where things are still not working, that's when you want to consider using things like omalizumab or Xolair, because again, that's going to be the most expensive, the most side effect prone set of drugs here. So in terms of like test questions, what I could ask you would be like, okay, a patient comes in, they're on this right now. What would be a reasonable next thing to try, right? And so if I said, okay, they're taking a low dose inhaled corticosteroid, but they're still having asthma symptoms, and like, how do you even determine if they're still having bad symptoms? One thing you can do other than them telling you is how often are they using their short-acting beta-2 agonist. If they're using it multiple times a day, that shows you they're not very well controlled, right? If they only have to use it once a week, then that's a much better sign. But let's say they're still using their short-acting beta agonist several times a day. they're on their low dose inhaled corticosteroid, and I give you options. And I could say, well, use inhaled corticosteroid plus long-acting beta agonist. That would make good sense. If I said add on theophylline, well, that's probably not as good because we have other things we could do first before busting out theophylline, and there's no good indication, and it's a lot of side effects, right? I could say oral corticosteroids. Again, not good for long-term control, so I wouldn't do that either. And I could say something like, Xolair, omalizumab. Well, that's not really the time for that either, right? I have other things I could do in the interim. So I'd kind of want you to, on a stepwise approach, what seems like a reasonable thing to do next in terms of how you would scale up therapy, or maybe even scale down therapy, right? Say a patient was on, Xolair, Singulair, and long-acting beta agonist and inhaled corticosteroid. What would you come off of first if they're well controlled? I'd probably come off the Xolair first. It's most expensive, most side effects I'd be worried about, like anaphylaxis. So think about how you move up and down this ladder here based on how well controlled or not controlled they happen to be there. So that's the kind of questions I'd probably ask. So in terms of like using the inhalers themselves, there's some things we can do to try to help with technique for these patients here. Basically, we have things like spacers and valve holding chambers. These allow for the drug to be suspended within this chamber that allows the patient to kind of breathe it in on their own time, so to speak, because there is a degree of dexterity needed in order to utilize these inhalers appropriately. The whole point being is you have to get particles that are of the correct size in order to get into the lungs where they need to be. The particles are too big and heavy, they just fall down and hit the tongue or the back of the throat and go down to the GI tract. Need them to be respirable, so able to be gotten down into the respiratory tract itself, right? So how do we do this, right? So basically, you want to make sure when patients are utilizing a meter dose inhaler like this, one that has to be squeeze the canister to get the drug out, make sure they shake it up first, because a lot of times you want to make sure the drug is adequately suspended throughout the solution in there, because they have a tendency to separate out over time. So shake them up first, have the patient breathe all the way out, to have forced expiry phase, and then they will hold the inhaler as below. Typically, I have them put their lips on the mouthpiece so that we avoid, drugs kind of getting out into the atmosphere. And then what I'll tell them to do is to start breathing in, not real fast or anything, but just start breathing in normally. And as they're breathing in, you sort of create an airway. You sort of create a pathway for that drug as it gets introduced into the airstream to get down into the lungs. Have them start to breathe in first, press down on the canister. That will then expel the drug and then into the airway, and then able to get into the lungs, hopefully. They'll then try to breathe in slowly and deeply, and then they'll hold their breath for about 10 seconds or so, or as long as they're able to comfortably. And then typically for drugs that require multiple puffs, so if you ever see like, albuterol 2 puffs, don't do both puffs at the same time. Give it 15 to 30 seconds or so, because what that first dose is going to do is to help open up those airways a little bit, and then it allows for the drugs to penetrate down even deeper on the second dose. So by waiting, you get more bang for your buck from the drug. And so if I kind of equate it to getting more value out of your drug, patients usually kind of respond better to that. So anyway, in summary, asthma is it's a chronic disease. It's important to understand how the drugs are working, whether for long-term control, for acute suppression of acute symptoms, things like that. And again, make sure you're able to understand how we're using these different drugs together and know how it makes sense in various contexts there. So there's a few cases here where you can have something called status asthmaticus, where you have really severe asthma symptoms that are not being responsive to traditional treatment like corticosteroids and continuous albuterol and all of that. So this is like patients who are going to end up going to the ICU, potentially being intubated. Just so you know some things we can do for them. This can include a continuous stream of albuterol. Instead of using like a meter dose inhaler, using like 2 puffs, this is just going to be a nebulizer constantly running and basically giving this patient a continuous stream of albuterol to breathe. One way we can do that. Obviously, IV steroids are going to be utilized here. And a few things we can do alternatively includes magnesium. You're like, well, magnesium, why are we going to do that for an asthmatic patient? Kind of cool here. Magnesium actually works as a smooth muscle relaxant. You can give a bolus followed by a continuous infusion of this. It allows for the bronchial smooth muscle to relax. So if you ever see an asthmatic patient getting magnesium, that's what that's for. And then ketamine is really kind of interesting because this is a sedative agent, and we'll actually do this if patients end up getting intubated. because it will actually cause bronchodilation to occur in addition to keeping them sedated and allowing them to breathe on the ventilator there. We'll probably talk about sedatives a little bit more when we get into the surgery section later on this semester here. But with ketamine, just be aware, patients can have hypertension, tachycardia, because it's basically a stimulant. That's why it causes that bronchial smooth muscle relaxation to occur, because it's kind of stimulating all the respiratory tract and cardiovascular system. You can also have what we call an emergence phenomenon, where basically when patients wake up after getting ketamine, they get very agitated and aggressive. We can talk about more of that later, but just as an idea of kind of some common things you may see with ketamine. And then sometimes for a really severe case, I've even seen aminophylline being busted out. Again, that's the IV form of theophylline, but that's pretty rare. We would need that. Okay, so bridging into COPD, we're going to find that the pathogenesis here is different, right? Because we're actually having kind of long-term destruction of the airway due to like smoking or whatever the inciting event happened to be. Whereas with asthma is totally reversible, this is going to be eventually a non-reversible cause of airway resistance, right? And again, you have a lot of reserve in the lungs in terms of function. As that decreases over time, you'll have an asymptomatic period, and then you eventually find that your symptoms are going to get worse and worse and worse as that function continues to decline. And obviously, the best thing to do for these patients would be probably to go ahead and give them a new set of lungs, but that's not going to happen in a lot of cases there, right? So I kind of want to give you an idea of, we're going to use the same drugs, but how we're going to use them a little bit differently here. So first off, smoking cessation is going to be the number one thing you can do for these patients here, if they are smokers. Obviously, there's other causes for COPD, but this is probably far and away the most common. Other things we can do for these patients to include make sure that they are covered for common infections they're at risk for. That includes influenza and pneumococcal vaccine to make sure that they are protected against that. Getting into the actual long-active drugs, this is where you want to start to consider utilizing your short-acting bronchodilators for acute treatment of symptoms. So again, you can get away with short-acting beta agonists like albuterol. That works totally fine there. Then we're going to get into long-term bronchodilators. So you can utilize a long-acting beta agonist by itself for these COPD patients, and that's fine. You can use salmeterol or formoterol by itself. That's reasonable. You could use an anticholinergic here as well. So this is where that tiotropium or Spiriva comes into play here. So you could use something like salmeterol and tiotropium, and that would be a good combination for your COPD patient that you probably wouldn't use for an asthmatic patient. It just doesn't work as well for them. Those are kind of your first stops. And then you can also consider utilizing long-term corticosteroids for these patients as well. Although this is going to be a little bit higher up on that list, you'd probably use this a little bit later than you would for a typical asthmatic patient. There also is some role to play for theophylline, so you may see some patients who will get some benefit from that as well. So you're more likely to see a COPD patient with theophylline than you are an asthmatic patient, most likely. Okay. So these are all kind of the drug therapies you utilize for COPD. Notice as well, this is also where you want to consider things like supplemental oxygen, obviously, surgery, things like that, which are kind of outside of our wheelhouse here. But I just want to see how you use the drugs a little differently for COPD than you would for asthma necessarily. Okay. Last thing I want to talk about today is going to be our smoking cessation. This is an important thing for anyone who is smoking, because we do know a lot of the risks for things like cancer and COPD and things of that nature for patients who are chronically smoking. Now, again, I don't go a lot into vaping yet because it's still a relatively new thing in terms of use for smoking cessation, but we'll talk about nicotine replacement a little bit here. Biggest thing, though, is that, nicotine is an addictive substance. It doesn't matter how you get it, whether you're vaping it, smoking a cigar or cigarette, doesn't matter. It's an addictive substance. So it's very difficult for patients to come off of this because some of them have been having exposure for decades. And so the biggest thing here is to try to prevent withdrawal symptoms. Their body's so used to having nicotine around that if they start to come off of that and get their levels drop down, they're going to have intense cravings, they're going to feel miserable. So they need something to help try to mitigate that. So in addition to ways we can do that with drugs, we're also going to see that helping with coping with kind of the psychological or social aspects of stopping smoking are important too. So that's where utilizing therapy, using things like cognitive behavioral therapy in addition to medications are going to be very synergistic, and you got to do both, because otherwise the failure rate for these substances are going to be pretty common, as we'll see. Okay, so we have a couple different options here. So we're going to talk about bupropion, what are nicotine replacements, and then finally varenicline or Chantix here. Bupropion is actually something we'll talk about more in the behavioral health section, because this is originally is a an antidepressant drug, and basically what this does is we'll talk about the addiction pathway and the mesolimbic pathway and stuff. But basically, the reason why nicotine is addictive is because it activates the mesolimbic dopamine pathway. Basically, it's a reward pathway for if you have a food that you really love, if you have sex, if you have heroin, all these substances that trigger your brain to think, wow, that was really good. I would like to get a lot more of that. Nicotine does the same thing. And one of the things that bupropion does is it helps to regulate that dopamine and try to help kind of reset that reward pathway. So that way you don't get the same sort of enjoyment out of nicotine, and hopefully can kind of disrupt that. So when you come off of the nicotine, the withdrawals are not so bad. The cravings are not so severe because all of a sudden your dopamine levels go to like 0, right? Because you're going cold turkey, for instance. So, and one of the important things I'm going to mention here about use of these drugs here is, can you use them with nicotine? If a patient falls off the wagon and goes back to smoking, is this going to be a problem for the drug? And so in this case here, no, they can actually smoke along with being on bupropion. That's going to be okay. There's not going to be no interactions here. So that's important enough from a safety standpoint. This will be something that will be important to hear in a few moments. So anyway, so you do want to be cautious here. Bupropion can lead to seizures in patients who have a history of seizure disorders. And you also want to make sure patients are not taking other antidepressants that could interact with bupropion, which we'll talk more about antidepressants later. But basically, if they're taking like a TCA or a tricyclic antidepressant or venlafaxine, these do not mix well with bupropion and lead to increased side effects. So do not mix and match those. But if the patient has depression already, then bupropion may be a good option for them if they also want to quit smoking. So the next thing we could do is just replace the nicotine that they're getting, and as a means of trying to slowly wean them down off of their dose. So if they're smoking 1 pack a day, give them a roughly equivalent replacement amount, and then slowly wean them down to basically nothing. This can be helpful because basically it minimizes those withdrawal symptoms, the anxiety and restlessness and all of that. And then you'll find there's different dosage forms that are available, some of which may be able to help even when like the physical dependency or not physical dependency, I should say, but more so just like the physical act of smoking. So if they have like a little inhaler that is shaped like a cigarette, they can kind of hold like a cigarette. That kind of helps to replace that physical manifestation of smoking that they used to have, and it helps keep that habit there. So, and again, a lot of this is psychological, right? So it means of trying to help them prevent that craving, that need to get back to their original nicotine source. So there's patches that are available, there's gums that are available, lots of different means to do this. You want to be careful though, because if patients fall off the wagon and they go back to smoking again, you're going to find that this, in addition to their smoking, may lead to even higher nicotine levels than they're used to, and that can lead to a lot of side effects. So do be careful with that. Be careful in patients of hypertension, history of tachyarrhythmias, because this can be exacerbated by nicotine. So cardiovascular stimulant, so you do want to be careful in those patients there. Okay. Again, this can be very useful because it helps to prevent those withdrawal symptoms. And then finally, we have Chantix here. This is going to be a partial nicotine receptor agonist. This is kind of interesting because it only partially activates a nicotine receptor, but it also binds really tightly and prevents nicotine from interacting with it. So what we do for these patients here is they will actually start Chantix a week before their quit date. And then once that they kind of get good levels of Chantix built up, then they quit smoking. And that way, even if they continue smoking on top of that, it doesn't really interact with those receptors, and so it kind of prevents that the nicotine from really working as well. That can be one benefit to there. And they'll try for about 12 weeks or so, and then try to see if they can come off of it and see if they're, hopefully stay abstinent from the nicotine again. The interesting thing with Chantix though is it does have a black box warning for some of these neuropsychiatric events, and like really vivid dreams is one of like the most common things I'll hear people talk about with Chantix. For whatever reason, this partial nicotine receptor activation causes very vivid dreams. Some people like them. Some people say they're too real. There's been cases of worsened depression, suicide ideations. So this would not be good for those kind of patients, right? So I could say, okay, someone is a smoker, they want to quit, but they have a history of depression. Which one of these would be good for that? Well, Wellbutrin or Zyban would be good for that. Bupropion, because it helps treat depression. Chantix may be a bad option for them because it could worsen depression. So little things to think about in terms of contraindications and side effects and whatnot. As I mentioned, Treatment for or prevention of infections is important because people with COPD do have risk for infection because they've kind of just altered their respiratory tract to make them more susceptible to things like pneumococcus and whatnot. So make sure they get their annual flu and make sure they also get the pneumococcal vaccine in order to prevent unnecessary infections there. And so I finished right on time, which is fantastic. And so there'll be a pulmonology quiz you'll do this week. I think I may do either by Sunday or next Tuesday when we meet again. But regardless, get that done and let me know if you have questions about that. And then otherwise, I think we'll be set up to start GI next week. So any questions from you guys right now? I know it was a lot, but I think it was good kind of getting back into the swing of things kind of right off the bat there. Anything at all? If not, you guys are free to go. I'll stick around for a minute or two to see if anyone has questions, but definitely make sure that if you do have questions, feel free to email me. I'm always available to you guys, even though I'm distant from you all. And yeah, if you have any issues with the way the course is set up in terms of Blackboard, I still have some challenge with that. I'm so used to using Canvas, which I've used at other universities. So Blackboard's a little more archaic, and so sometimes things kind of get out of sync with me on that. So if you see something that doesn't look right, let me know, and I can try to go in and troubleshoot it. So otherwise, you guys are free, and have a great rest of your week. Question. I'll let you guys go. Have a good one.